Welcome to our webinar, Genetic Testing for Acquired Bone Marrow Failure Diseases. Thank you for joining us today. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. It is possible you may lose your connection during the program. If you lose your connection, please call in using the call-in number in your reminder email to hear the audio portion of the program. Today's program will be archived to our website within just a few business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your question at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in your question or comment in the small text box window, and when you finish typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your personal health care. Our specialist today is Jadee Neff. Dr. Neff is an assistant professor in the this is tongue-tied here. Hematology and molecular genetic pathology, Assistant Director of Molecular Pathology, Genetics and Genomics Clinical Laboratory, Associate Director of Genomics in the Biorepository and Precision Pathology Center, Director of the Molecular Genetic Pathology Fellowship in the Department of Pathology at Duke University Medical Center. As a diagnostic hematopathologist and molecular genetic pathologist, her clinical focus is on histologic examination of tissue and bone marrow biopsies to diagnose hematologic malignancies such as leukemia, lymphoma, and myeloma, as well as testing DNA for tumors or for blood to detect inherited and acquired mutations that can guide therapeutic management and predict clinical outcomes for patients. It's my pleasure to welcome Dr. Neff.
Thank you. Thank you. Let me get my slide here. All right. Thank you for that introduction. Again, my name is Jadee Neff. My main job here at Duke is I'm a pathologist, and so I look at bone marrow biopsies and peripheral blood, and I help to diagnose bone marrow disorders and things. And then I also am part of the molecular lab, so we do molecular testing on solid tumors and on blood specimens. But today I'm going to talk about genetic testing for acquired bone marrow failure diseases. Get my slides again. There we go. I have a couple of disclosures. I am a speaker and a consultant for USA Pharma and a consultant for AbbVie and GuidePoint Global, but none of these financial relationships have anything to do with the content of this presentation. So for today's talk, I'm going to start out and talk a little bit about normal hematopoiesis. Then I'll talk a little bit about how we work up a patient who has a cytopenia. And then I'll talk about 4 different acquired bone marrow failure diseases, and those include pure red cell aplasia, paroxysmal nocturnal hemoglobinuria, aplastic anemia, and myelodysplastic syndrome. So all blood cells are basically born in the bone marrow. Essentially, you have this spongy material inside your bones, and they're going to be more in your long bones, so like in your hip bones or your femur. leg bones. So this spongy material contains what we call hematopoietic stem cell precursors. So these are cells that can turn into any kind of cell type, and they live for a very, very, very long time in your bone marrow, and they will divide and reproduce themselves and stay in this potential state. And when they decide to differentiate, they can go down a couple of different pathways. The first is the lymphoid progenitor pathway, and those go on to become lymphocytes. And there are different kinds of lymphocytes, and they circulate in your blood. The other pathway is the myeloid progenitor pathway. So these are cells that then go on to turn into your granulocytes that circulate in your blood, monocytes and things that also are sometimes in your blood and sometimes in your tissues. And also these types of cells become platelets and red blood cells. So what is the role of all these different cells in your blood? Well, the most prominent cell type in your blood is the red blood cell, and that's of course what gives your blood that red color. These cells are what I call the gas transport cells. Basically, their function is to deliver oxygen throughout the body and then to transport carbon dioxide and have it go back out of your body through your lungs. The platelets are these red circles, those are your red blood cells. These small little purple dots here, those are your platelets. And I like to call these the Band-Aid of your blood cells. So their whole function is to basically stop bleeding. So if you get a cut or something, basically if a blood vessel breaks or is damaged, the platelets are going to sense that, and they're immediately going to lay down over the damaged area and create a crisscrossing network along with other components of your blood called clotting factors and things, and they'll form a scab or a clot and then promote healing. You have other cells called white blood cells, and there are lots of types of white blood cells. The most common are these here. They're called neutrophils. They have granules. Eosinophils have these red granules, and then basophils are very rare, but they have these big purple granules. Together, these are called granulocytes, and their main function is mostly to do with immediate immune responses. So I call these the first-line soldiers. If you have a splinter and it's got some bacteria on it or something, these neutrophils are going to be the first cells there, and they're going to be releasing molecules and things that help get rid of that infection. Their main role is to fight infections, but they are also play a role in wound repair. So again, if you have a wound or something, these neutrophils and other granulocytes will show up to help repair that. Then you have lymphocytes. These are the second most common white blood cells in your blood. These lymphocytes are smaller. I like to refer to them as the special forces. So when a lymphocyte first comes out of the bone marrow, and they have to be educated as to what is a bad thing, what is an infection, or what is a bad cell, before they can go and do something about it. So I call them trained to fight. They are what's responsible for our immunological memory. So anytime you get a vaccine and you're developing an immune response to it, that is thanks to these lymphocytes. And most lymphocytes fall into one of two categories. We call them T cells or B cells. T cells are responsible for directly killing other cells. So maybe you have a cancer cell that has formed in your body. T cells can go in and kill that directly. Or maybe you have a cell that has been infected by a virus. Again, a T cell will go and get rid of that cell. B cells make antibodies. So those are, for example, when you get vaccinated and they want to measure your vaccine response, they measure your antibody levels. That's all thanks to B cells that are making antibodies for you. And antibodies are proteins that go around and they find bad things that aren't supposed to be in your body, like bacteria or whatever, and they bind to them so that your body can clear them away. Now, the last type of cell is called a monocyte. These are large cells that I call them part of the cleanup crew. So they do a lot of phagocytosing, or what we call like eating. They will phagocytose or eat things that have been coated by antibodies. So let's say you have a bacteria, B cells make your antibodies, and they're going to coat that bacteria with these antibodies, and then the macrophages or the monocytes will come in and eat them. Anytime you have a wound or something where the neutrophils have already gone in and they've done their work and they're done, again, the monocytes will come in and they'll clean up everything. And they also help make scars as part of wound repair. All right, so when we are assessing somebody, when we're assessing their hemostatic status, we use a lab test called a CBC, or called circulating blood count. And we add on to that often a differential. So a CBC, that's going to look at these top four things here. So it's going to measure how many white blood cells you have in the blood, what is your hemoglobin, and then a related value, your hematocrit. That's sort of a measurement of how your red blood cells are doing. And then they're going to get a platelet count. And then when we add on a differential, that's where we're going to count how many different white blood cells there are, and we'll classify them. Neutrophils, lymphocytes, monocytes, eosinophils, and basophils are standard counts, and then if we see any other cell type, like blast or something, we'll count those as well. So I've listed here the normal values for these. These are general, and the exact values are going to vary slightly from laboratory to laboratory. But basically, anytime you get a CBC, they should print the normal values, and you can see how you compared to what should be normal for that lab. So cytopenias are defined as having too few cells. So anemia is too few red cells, so low hemoglobin or low hematocrit. Thrombocytopenia is too few platelets. Leukopenia in general means too few white blood cells. They can be more specific and call it a neutropenia or lymphopenia. That's where they're specifically saying too few neutrophils or lymphocytes. And of course, when they use the term pancytopenia, that means that all three cell lines are decreased. So your red cells, your platelets, and white cells, or at least some component of your white cells, like your neutrophils, are decreased. So what does it look like when a patient has anemia or low hemoglobin? Basically, people with anemia will be tired all the time. So essentially, you have to think about they don't have enough oxygen getting around into their, throughout their body and things, because they don't have enough red cells to perform that function. They can be tired, they can be pale. So here's an example of this is their normal skin tone, and they're pale. Other person is very pale. You can feel lightheaded or dizzy, especially if you stand up, and those may be signs of anemia. If a patient has thrombocytopenia, basically the symptom would be bleeding. So you can have unexpected or frequent nosebleeds, or what's called petechiae, and these are tiny little pinpoint sort of maroon to purplish colored dots on your skin. Those are petechiae, and they could be a symbol, a sign of thrombocytopenia. If patients have neutropenia, so specifically low neutrophils, the symptoms of those are basically frequent infections. So these patients will present with several instances of cellulitis, maybe require hospitalization, or pneumonia. A chest x-ray of a person with pneumonia, and this is the lobe of the lung that's affected. This is a picture of an invasive fungal infection. Again, somebody who's severely neutropenic can get fungal infections deep in the tissues. So what do we do to work up cytopenias? Well, if a patient presents to their physician with cytopenia, of course, the first thing you would get is a CBC, and if they confirm cytopenia, they're going to look for other causes. But if it's severe enough and they don't figure out the other causes just from other lab tests or giving you iron supplements or something like that, then you may need to get a bone marrow biopsy. So bone marrow biopsy involves putting a needle into the hip bone through the back, and we get two things out of it. One is a needle core, or core of bone, and that's what you see here in this picture. And the other thing we get is what's called a bone marrow aspirate that allows us to look at the individual cells very closely so we can see exactly what they look like and what do their nuclei look like and things like that. When we look at a bone marrow, one of the first things we consider is the cellularity of the bone marrow. So cellularity refers to the ratio of cells compared to fat. So in this picture here, all these white circles are the fat. And over here, we have fat, more fat. And then all this pinkish, purplish stuff, these are the cells in the marrow. So here on the left, so this bone marrow is about 70% cellular, maybe 80%. This would be a normal bone marrow in a patient who's about 20 to 30 years old. But as we age, our bone marrow is replaced more and more by fat, and we have fewer cells. And so this bone marrow over here is about 30% cellular, and that's about normal for what we would see in a 60 to 70-year-old. And then you can imagine, the ages in between would be some variation between what's on the left and what's on the right. All right, so what are the different causes of cytopenia? Most commonly, these are going to be extrinsic causes, or what I call extrinsic, as in not due to something that's happening in the bone marrow, something that could be transient. So nutritional deficiencies are very, very common. If you don't have enough iron intake, or maybe if you have a slow bleed somewhere, that can give you essentially low iron and you can have anemia. Other vitamins include B12 or folate that are important for hematopoiesis. So if you're low in those, you can have anemia and other cytopenias. You can have toxicities. So lead toxicity can give you anemia, and zinc toxicity. You can have toxicities from alcohol consumption. So people who consume a lot of alcohol, that can interfere with hematopoiesis, and they can present with cytopenia. There are certain medications that are specifically, they call it myelosuppressive. So some side effect of the medication inhibits production of blood cells from the bone marrow. Certain infections can inhibit hematopoiesis, especially certain viral infections that can target your hematopoietic system. And then, of course, autoimmune diseases can also lead to cytopenias. Then, if a clinician rules out these other causes, like, for example, the patient doesn't have a history of autoimmune disease or drink alcohol or whatever, and they've ruled out the other causes, then we start to consider intrinsic causes. So together, these are what we can call bone marrow failures. And these include acquired bone marrow failures, which I've circled here, and then also all the inherited bone marrow failure syndromes. And you may have heard of some of these, like Fanconi anemia or Diamond-Blackfan anemia. These inherited bone marrow failure syndromes, basically it's a gene that a person will inherit from their parents, or maybe they develop it at birth, but it's a gene that they're born with that causes bone marrow failure. And they often present when they're very young, in their teens or maybe early 20s or 30s. But the acquired bone marrow failures present often later in life, in adulthood. And specifically, I'm going to talk about these four here, which I already mentioned earlier. So pure red cell aplasia. Pure red cell aplasia is a failure of red blood cell production specifically due to the destruction or loss of the erythroid precursors. So in a patient, only the red blood cells are affected, so they will only present with anemia. And basically, they will only present with symptoms of the anemia. So the fatigue, the being pale, lightheaded, things like that. Diagnosing pure red cell aplasia is fairly straightforward from a hematopathologist perspective. Basically, in the CBC, so in the peripheral blood, it'll show anemia and it'll show no reticulocytes. So reticulocytes are young red blood cells. And reticulocytes shows that the patient is not having a proper response to their anemia. In the bone marrow, basically the overall bone marrow will look fairly normal, maybe slightly hypocellular, so slightly more fat than one would expect. But basically it will look normal for age, except there will be a distinct lack of erythroid precursors. So if I were to look at this marrow and look closely, I would see the granulocyte precursors, I would see the megakaryocytes, which are the platelet precursors, but I wouldn't see any erythroid precursors. And so that's how I would diagnose pure red cell aplasia. Now, what causes pure red cell aplasia? It actually turns out there are lots of different things that can cause it. Over here you can see this graph that breaks it down. Basically, you have things like viruses, medications. The viruses, particularly there's a virus called parvovirus B19. That actually infects red blood cell precursors specifically, and then it causes them to die. So specifically, they can give you a pure red cell aplasia. Certain medications and things can cause it. Thymoma is a large cause of pure red cell aplasia. So a thymoma is a growth in your thymus gland, and it can cause, when people have thymomas, they develop a lot of autoantibodies. And so autoantibodies are antibodies that go throughout your body, and instead of attacking bacteria and other bad things, they attack the patient themselves. So they can get a lot of autoimmune type diseases from a thymoma. And one of these autoimmune type diseases would be a pure red cell aplasia. So the autoantibodies would attack the red cells. Another common cause of red cell aplasia is what's called LGL leukemia. LGL leukemia so LGLs are a type of lymphocyte, and normally we have LGLs. They are part of a response against viruses and things. But if you have too many of them, and if they attack red blood cells instead of attacking, virus-infected cells or whatever, then you can develop a pure red cell aplasia. And then there's idiopathic, meaning we don't know what's causing the pure red cell aplasia. As far as the genetics are concerned, it turns out that slightly less than half of cases have a mutation in a gene called STAT3. And that's interesting because STAT3 is also a common mutation that's found in patients who have LGL leukemia, even when they don't have pure red cell aplasia. So there's some overlap there. But there are many patients who have STAT3 mutations with other etiologies of pure red cell aplasia, and then there are patients who don't have STAT3 mutations. So the genetics is not completely defined yet. And here over on the right, you can see some genes listed, in the different diseases. So this is LGL leukemia, this is the pure red cell aplasia, this is aplastic anemia. So again, there's not really a defined genetic signature for pure red cell aplasia, mostly because the etiologies are so different. How do we treat it? Again, it depends on what's causing it. So if you know the patient has a virus, like if they have parvovirus, basically you support them through their viral infection. If they need to have transfusions or something, you give that to them. You want to boost their immune system. So if they have a virus infection because they are immunosuppressed, maybe you modulate the immunosuppression or something so that their own immune system can then fight off the virus. Basically, you support them until the virus is cleared, and then they should be able to regenerate their erythroid cells. If they have thymoma, basically the cure for that is to remove the thymoma. And for almost all of the autoimmune-related conditions that go along with thymoma, almost all of them resolve when the thymoma is removed. For LGL leukemia and the idiopathic kind, so if we don't know the reason or if we know it's LGL leukemia, here the treatment is an immunosuppressive therapy. So it's kind of opposite of the virus-associated pure red cell aplasia. So that's why it's important to be able to distinguish what's causing it. But if you don't know what's causing it, or if you know it's LGL leukemia, you give some type of a therapy to suppress the immune system, and then that thought is that that will turn off that autoimmune type of reaction and allow your red cells to regenerate. Paroxysmal nocturnal hemoglobinuria. So this is a disorder characterized by the destruction of cells. It can be any type of blood cell. All three types can be affected, although the red blood cells are the most often affected. The symptoms basically depend on what type of anemia you're presenting with, but they can include fatigue, bleeding, or infections. And in particular, many patients present with dark-colored urine, especially at night or in early morning. And that's because this particular disease, which causes the destruction of the blood cells, they cause what's called hemolysis of the red blood cells. Hemolysis is where the red blood cells burst open in the blood. And all that hemoglobin that leaks out is what colors the urine dark. So the diagnosis of paroxysmal nocturnal hemoglobinuria is, again, it's another fairly straightforward diagnosis, but you have to suspect it and you have to order the right test. So again, the CBC will show usually anemia and sometimes other cytopenias. The bone marrow will basically look normal. So it will have normal cellular marrow, maybe slightly increased. This is a younger patient, so that's why it looks a little more cellular than the other bone marrow is showing you. They'll have a normal cellular marrow, maybe slightly increased marrow, and what they will see, in contrast to the pure red cell aplasia, which didn't have any erythroid precursors, here there are a lot of erythroid precursors, so they're regenerating. So basically, they're younger, what we call left shifted. They're responding to this destruction of red blood cells in the peripheral blood, and your bone marrow is responding and it's trying to regenerate, and that's the look that we see. Basically, as a pathologist, if I see this, I would say marrow looks regenerative, consider all these other things, but it's not, from my look, it doesn't look like it's failing. It's just one snapshot. But the key is to order a special test called flow cytometry to look for PNH. And the flow cytometry test will be able to see the characteristic findings on the red blood cells or neutrophils to be able to diagnose PNH. So how does PNH work? So basically, PNH is due to a loss of protection against complement. Complement is part of your normal, it's part of your immune system. It's a normal component of your immune system. Complement basically consists of a lot of different proteins, and they all start with the letter C. So like C3, C5, those are pictured here. Here's C9. They float around in the blood, and they find cells to attach to. And there's this whole cascade where one will get activated after another, and the end result is to form this giant hole in the cell membrane and kill the cell. Now, this is normally supposed to happen on bacteria or cells that should be dying anyway. So normally, in your tissues, we have other cell membrane proteins like CD55 or CD59 that block the complement process. So here's a normal red blood cell. There's normal complement in the system doing its thing. It lands on the membrane, and normally it would go to activate its next step in the pathway, which is C5. But this protein here, CD55 and CD59, it blocks that pathway, and therefore it protects the red blood cell. But in a patient with PNH, they don't have this protein anymore on their red blood cells, and so this pathway can be allowed to proceed. So the C3b activates its partner, C5, and then C5 joins with the others and makes the pore, and then the red blood cell dies. And then this is all the hemoglobin that's being released into the blood, which then will turn the patient's urine dark. What is the genetics behind this? Well, it turns out that patients with PNH have a mutation in the PIG-A gene. Now, the PIG-A gene, PIG-A is a protein that's responsible for attaching other proteins to the cell surface. So when PIG-A is not around, then other proteins like CD55 and CD59 can't attach to the cell surface like they're supposed to. And that's why they're not on the cell surface anymore. There are other cell surface proteins that also don't attach like they're supposed to, and they may have other effects, but this particular loss of CD55 and CD59 is what causes the destruction of the red blood cells. Now, it turns out that PIG-A mutations alone aren't enough to cause PNH or the loss of all of your, basically a bone marrow failure. It's not enough. So you need two hits. So PIG-A alone, all it does is it makes the red blood cell susceptible to attack from complement proteins, but you actually need some type of an immunological stimulus to upregulate all the complement proteins that then goes and causes the red blood cells to die. So it turns out, and there are many patients who have mutations in PIG-A, and then those mutations go away on their own because they don't have a second hit that allows it to progress to a bone marrow failure. So frequently in patients with the full-blown PNH and sort of that bone marrow failure presentation, they have other genes that are mutated along with it. So BCORL1 is the most common, or the next most common mutated gene, but then there are these others here. And these other genes are what then allow those cells with those mutations to last for a really long time, or to grow out and become a dominant population. So how do we treat PNH? Well, the first treatments that were developed were antibody-based treatments. So eculizumab and ravulizumab, these are monoclonal antibodies. They actually bind to C5, and they prevent, they bind to C5 on the surface so that these cells are then eaten by the macrophages or the monocytes, and then basically those cells are gone from the system, and they don't have a chance to burst open or anything. Then afterwards, I don't know how to pronounce this very well, pegcetacoplan is a small molecule inhibitor, and this inhibits C3. So it inhibits, they both attack the complement system, but basically it binds to C3 and prevents it from doing its next step of going to C3b. And then basically then you don't have the C3b on the surface. And so those cells will be protected from complement-mediated lysis. Aplastic anemia. So aplastic anemia is a term that describes a condition when basically your bone marrow stops working altogether. Essentially, all three cell types are going to be affected, and these patients often present with profound pancytopenia. Symptoms are going to include all the sequelae of decreased blood cells, so fatigue, bleeding, increased infections. And here again, the diagnosis is fairly straightforward from a pathologist perspective. The CBC is going to show pancytopenia, and the bone marrow is going to show marked fat replacement. So I would describe this as a pathologist, I would say this is markedly hypocellular. Basically nobody, no matter how old you are, should have a bone marrow that looks like that. Then looking closely, there's the absence or near absence of all hematopoietic precursors. So what causes aplastic anemia? A specific mechanism hasn't been described yet, not unlike PNH, where we kind of know what's causing it. In this case, though, it's thought that there is some degree of immune-mediated destruction of the hematopoietic precursors, and also something defective with the bone marrow stroma. So those other cells in the bone marrow that are supposed to supply nutrients and other things that keep the hematopoietic precursors alive and happy, somehow there's a defect there too. So basically, if you have direct killing, now you're no longer able to make the downstream blood cells, or if you have some sort of inhibition in the self-renewal process or whatever, you get the same result of cancer. So what are the genetics that are involved? Well, it turns out that there are many genes that have been shown to be involved in aplastic anemia, or when a patient presents with aplastic anemia. And several of the most common you may recognize from the P&H slides that I showed you. So PIG-A, almost a quarter of patients with aplastic anemia have mutations in PIG-A. And also, if you include the BCOR, BCOR-L1 mutations, that's a little over a third of patients. And over here on this side, these genes tend to be things that you see in MDS. So it's interesting that patients with aplastic anemia have a variety of mutations that can be seen. The other interesting thing about this is that the type of mutations that are seen in aplastic anemia actually predict how well the person is going to respond to immunotherapy and how well they're going to survive overall. So if a patient with aplastic anemia has the sort of the P&H flavor of mutations, in other words, like PIG-A mutations, BCOR, BCOR-L1, they actually do quite well. It's represented by the blue line here. So this axis shows overall survival, it shows months, they do pretty well. If a patient has aplastic anemia and presents with these mutations over here on the left side of the circle, so those MDS flavor of mutations, they actually don't do as well. So how do we treat aplastic anemia? To my knowledge, there aren't great treatments yet, at least outside of clinical trials, that affect the stroma component, but we do have treatments that basically target the immune-mediated destruction component. So basically, the clinician will devise some type of immunotherapy, immunosuppressive therapy that dampens the immune system. And the hope is that we catch the aplastic anemia early enough that we stop the immune-mediated destruction and allow recovery of the bone marrow. Myelodysplastic syndrome. So MDS is a type of blood cancer that impairs normal blood cell production. It can affect 1, 2, or 3 cell types in the blood. And again, the symptoms are going to depend on what cell type is affected. In my practice, usually I see people presenting with thrombocytopenia, so they have like bleeding episodes or petechiae, or a little more commonly is anemia, and they'll present with fatigue. The diagnosis of myelodysplastic syndrome can be tricky, but usually it's easy to distinguish MDS from the other bone marrow failures that I talked about. Usually, so again, in the CBC, you'll see at least one cytopenia. Usually the marrow is very hypercellular. So this marrow is from a patient with MDS, and they are, 60 or 70 years old. So you would never expect to see that many cells in a 60 or 70 year old. Usually they will present as hypercellular, and then the key would be finding dysplasia. So that's where the hematopoietic precursors look abnormal, and I have drawn little arrows here pointing out some of the abnormal precursors that I'm seeing here. However, there's a really tricky subtype of MDS called hypoplastic MDS. About 15 to 20% of MDS patients have this subtype, and basically their bone marrow is hypocellular, so it will look almost identical to an aplastic anemia bone marrow. And oftentimes these can be confused, and the key to distinguishing them is to look for the dysplastic bone marrow precursors. But the problem is if you have a hypoplastic bone marrow where you don't have any cells, it's really hard to find the cells to look for to see if you can see dysplasia. So as a pathologist, when I get a marrow that looks like aplastic anemia, it's very, very difficult. And I look very, very hard to see if I can find dysplastic cells to really be able to guide the clinician and guide the treatment so that they can know how to treat this patient. Now, how does myelodysplastic syndrome start? Well, it's thought of as an accumulation of age-related mutations. So basically, if you look at any healthy person, as they age, it's just a normal part of life to develop these mutations. And the vast majority of these mutations don't do anything. So here in this graph, you can see that, if you're lucky enough to make it into your 90s, up to 25% of people can have a mutation in one of these genes. We call them myeloid genes. I'll show you the list in a minute. But 25% of normal, healthy people can have mutations in one of these genes. And as your gene panels get larger and larger, and you start to look at more and more genes, that percentage goes higher and higher. So again, most of these mutations are just going to be nothing. It's just going to sit there. So when we see that from a diagnostic perspective, we see a patient who's otherwise completely normal, completely healthy, but they just happen to have a random mutation in one of these genes, we call that CHIP, or clonal hematopoiesis of indeterminate potential. We don't know what it means. But it turns out that if these CHIP mutations accumulate and they happen to get a mutation in a gene that maybe gives a survival advantage to the cell, or maybe a gene that starts to give a proliferative advantage, that's what then leads to MDS and then eventually can lead to AML. And so we think about these random mutations as like the soil, maybe setting the stage, and you have seed mutations that, they're like a seed that's planted that maybe, allows the cell to live longer than it should. And then you have other mutations that can be randomly acquired that then start to cause uncontrolled growth. So the risk of progression of CHIP to MDS is about 1% per year. So again, it's very, very low. We have normal accumulation of these mutations in normal people. Once you get one, it's still a very, very low chance of progressing to MDS. So what are these genes that I'm talking about? In myelodysplastic syndrome, there's been a lot of studies as far as what genes are mutated. And if you ever get a myeloid NGS panel or NGS testing or something for a bone marrow failure, these are the types of genes that would be included on that panel. And essentially, it's thought that these genes affect a few key functions in the cell. One key function is DNA methylation. So there's a whole class of genes that affect how your DNA is methylated or not methylated. And DNA methylation is what causes genes to be turned on or off. So these mutations are affecting the cell's ability to turn on or off certain regulatory genes. And that can lead to uncontrolled growth or a survival advantage or not dying when they're supposed to. Another class of mutations affects the splicing complex. So splicing is what happens when you have a gene, which is on your DNA, and then an RNA copy will be made of that gene, and then that RNA needs to be spliced. So all the introns are taken out and you're left with the exons. It needs to be spliced properly before it can go out and create the protein that then does its job. Well, the splicing complex is important to make sure that the correct RNAs are made, or that the RNAs are made correctly. And if they're made incorrectly, that can give you a mutant protein on the other end, or a non-functional protein on the other end. And so again, having mutations in these splicing genes can affect the cell's ability to create its normal protein, normal function. And then you have a whole class of genes that are part of the cohesin complex. And this cohesin complex is, again, it's part of how your DNA, when your DNA is packaged up into chromatin, how it folds and how it's packaged, and that's going to dictate then what genes are available to be expressed or not expressed. So again, these MDS mutations are things that affect the cell's ability to act in a normal way and to make normal proteins. So you impair that ability, now all of a sudden you can have other processes happening like uncontrolled growth or not dying or whatever. So how do you treat myelodysplastic syndrome? This is basically going to depend on whether you have low-grade or high-grade MDS. Low-grade MDS has a lower risk of progression to AML. I've seen patients treated with nothing, just observation. Maybe their cytopenia is very minimal and the gene risk score is very low, and so these people are just observed. Or sometimes they're given supportive care, so maybe a transfusion every once in a while to bump up their red blood cells. I've also seen folks use what I've heard the oncologists call the gentle chemotherapies, or sometimes immunomodulatory types of therapies. But for patients with high-grade MDS, so these have a very high risk of progression to AML. I've seen these patients given chemotherapy and sometimes bone marrow transplants. So we talked about MDS, aplastic anemia, PNH. These conditions have a lot of overlap clinically. And I have other diseases listed here too, and these are like AML and other things that are more proliferative, but they all overlap, and they have, and they have a different phenotype. So those on this end, like aplastic anemia and hypoplastic MDS, they have sort of an immune injury type of a look, so immunologic component. And then, of course, those on this side of the spectrum, those have a more of a proliferative type of component. And if you look at the genes that are mutated in all of these conditions, there's a lot of overlap. So this list of genes here is essentially the same list that one would find in a normal NGS type of a panel. And you can see that they're mutated in a lot of these diseases. Maybe they're more or less prevalent in certain disease types. So what's interesting then is that a patient who presents with one of these bone marrow failure syndromes can progress to a different syndrome, and they can a little bit go back and forth. So I mentioned earlier a patient with high risk MDS, they're going to have more of that proliferative phenotype. They have a risk of about 50 to 70% of progressing. For low risk MDS, they have a 10 to 20% risk of progressing, and for hypoplastic MDS, that fits in with this low risk category. Patients who present with aplastic anemia, they can progress to PNH about 20% of the time, 15 to 20%, or they can progress the other way towards that MDS AML pathway. For patients with PNH, they can progress towards aplastic anemia phenotype, or they can less commonly progress towards an MDS. So how does this work? Well, it basically depends on what random mutations accumulate in your cells. So, in this picture here, you have a cell that has a random PEG-A mutation. So that's going to be sort of that possibly PNH phenotype. And then, here you have other mutations that help those mutated cells survive. And so now you have clinical presentation of PNH. But depending on what those secondary mutations are, they can then go on to develop that susceptibility to immune attack and develop that aplastic anemia type look where all the blood cells are just gone. Or they can develop that persistence and survival phenotype, and they can develop into MDS or AML. So as a pathologist then, when we're diagnosing a patient, that's what makes it very, very difficult to specifically define exactly where they are on the spectrum. So here's a picture of a patient, how much bone marrow they have, and they go, they become, aplastic. They sort of have a bone marrow failure look. They have cytopenia or pancytopenia. And this is the point that we see them as pathologists and clinicians. This is when we see the patients. And so, we may see a hypocellular marrow and we may see certain mutations present, but it's very, very difficult to say precisely which disease it is. And sometimes even if we can say which disease it is, again, the disease can change, can develop a different clinical phenotype or presentation. So we have overlapping symptoms on the clinical side. We have overlapping bone marrow findings. We have overlapping mutations, and the disease itself can be plastic. So sometimes a definitive diagnosis takes time, and we may need to treat the patient and just sort of observe how they go and do a lot of follow-up and maybe change treatment therapy as needed. So, for example, if the patient presents with bone marrow failure and we see the mutation, the PIGA mutation, and it looks like a PNH phenotype, then maybe we'll try the anti-complement therapies, see if that helps the patient get better. Or if they present with an aplastic anemia kind of a phenotype, then maybe we'll try with the immunotherapies and see if that helps, and so on and so forth. So, in summary, acquired bone marrow failures, those refer to the disruption of normal blood cell production. Not something that you're born with, but something that you acquire later in life. And they're due to a combination of immune factors, so the immune system attacking the blood cells, and also genetic factors, so random somatic mutations that are just acquired randomly. The clinical presentation is determined by which mutations become dominant. So it's the combination of mutations that determine whether you have the PNH flavor or the MDS flavor. So therefore, the disease course and the treatment may vary over time, and therapy may use a treat and observe approach. I'd like to thank you for your attention, and I'll open up for any questions.
Thank you so much, Dr. Neff. We have a few questions, and thank you for the presentation. Our first question is a bone marrow biopsy really necessary for genetic testing? I've heard the same can be accomplished with a tube of blood.
Yeah, that's a great question. So you're exactly right. The bone marrow biopsy itself is not required to do the genetic test because the mutations are going to be present either in the bone marrow or in the blood. The real purpose of the bone marrow biopsy is to exclude the other things. So to exclude, for example, AML, which is acute myeloid leukemia, can present with pancytopenia. So you want to get that to make sure that there's not something worse going on in the bone marrow. If your clinician is fairly certain that there isn't something worse going on and they're fairly certain that it's one of these things, then I think it's fine to go ahead and do a blood. But in general, if it were my relative, I would say go ahead and get the bone marrow at least that first time, just to make sure there's not something worse going on.
Thank you very much. Our next question reads, last year I had a bone marrow biopsy that showed a complex karyotype, including del9Q, and received a diagnosis of intermediate MDS. A repeat bone marrow biopsy this year showed no mutations. Can mutations have spontaneously resolved, or is it more likely that one of the bone marrow biopsy's results was either a false or a negative? I'm sorry, either negative or positive. I'm sorry.
Yeah, no, that is a fascinating question. Okay, so in general, obviously without knowing all the details, of the specific case, and I don't know whether you were treated in between, because if you were treated then yeah, you might have been successfully treated and you might have gotten rid of the bad clone. But let's say you didn't get any treatment at all in between. So I'm understanding your questions can be can a mutation go away? The answer is yes, depending on what mutation it is and what cell type it's in. So in my line of work, I don't often see mutations go away, especially if it's a complex karyotype. Usually that's going to stick around. But every once in a while, I see a patient where they have something that, maybe for whatever reason the clinician observes, they don't treat right away. And, on follow-up bone marrow, it's gone. And this is not a very eloquent response, but the only thing I can think is like, wow, that's great. Like, lucky you, it was just one of those chip mutations and that karyotype wasn't actually hitting something critical. And wow, lucky you. I think what your clinician should do is to continue to follow your CBCs, your blood tests, and just make sure that you continue to be fine. And if those numbers dip again, you may need to have another bone marrow biopsy to make sure things haven't come back again.
Thank you very much. Our next question, how does a pathologist select cells for analysis for flow cytometry or FISH? This person's bone marrow biopsy, it appears they only looked at 20 cells. How do I know if this sample is representative?
Yeah, that's a great question. Okay, so flow cytometry, you're going to look at like 100,000 cells, and it's not really selected. They just take a bone marrow aspirate, which is kind of like a tube of blood, but it's liquid bone marrow, and they're just going to stain it all and run it all. So we get a pretty good representation with 100,000 cells. For FISH, that's another type of assay that we use to look at chromosomes. FISH looks at 200 cells, and that's where somebody's going to sit down at a microscope and they're going to have like the cells spread out on a slide, and to be honest, they actually look at more than 200 from far away, and if they see abnormalities, they'll kind of hone in and make sure that those are in their count. But in general, the thought is the 200 cells is pretty adequate to get a good representation of what's there. What you're thinking of with the 20 cells is the karyotype. Karyotype is a much more complex process that involves culturing the cells in a test tube, and then finding the cells that are dividing so that you can actually see their chromosomes, and looking at those chromosomes to see if they're normal or abnormal. Because it's so labor intensive, they limit it to 20. And so you're right in the sense that they're only looking at 20. Now, again, they're going to scan through the whole slide, and if they find an abnormal one, they're going to be sure and count those abnormal ones. Or if they find something that's like borderline abnormal, they'll count 10 more, so they'll get a total of 30. But in general, they're only looking at 20 cells. The one thought, or that kind of counterbalances that, is that you're counting the cells that are actively dividing. And so the thought is, if you have a malignant cell in there, it's going to be actively dividing, and so you're more likely to catch it as one of your 20 cells.
Thank you, Dr. Neff. Our next question is, how do you tell which mutation is dominant when a patient has multiple mutations?
Right, great question. So most NGS reports nowadays will report what's called the variant allele frequency, or VAF. Basically, what it says is, so let's say PIG-A, for example. If I see a PIG-A mutation, it will say, I see, 30% PIG-A mutation. So out of all the times that I see PIG-A, 30% of them are mutated, and 70% of them are normal. They'll say 30%. So let's say you have multiple mutations, and you've got 30% PIG-A, but only 10% ASXL1. Well, then you might say, okay, it's a little more dominant towards that PIG-A side, versus if it was reversed and you only have like 5 or 10% pig A, but you've got, 40% DNMT3A or whatever, then you might say, okay, it's a little more dominant on the other side.
Thank you. Our next question is, when would you consider doing further genetic testing to determine if a genetic mutation is germline?
That is a great question. So there are a few germline, few genes that are frequently mutated in germline cases, or they can be mutated in germline cases and then can lead to myeloid neoplasms. These are usually included in NGS panels, and so the thought is that if you see a mutation in one of these, then you can consider going on and doing the germline test. DDX41 is one of them, GATA1 is one of them, things like that. The other way to consider a germline test is to actually look at how the person has presented with their condition, and look at the family history. Do you have other family members that also have similar conditions? And really, a genetic counselor is somebody who's going to be really good at figuring that out. And so if you have a patient who has a suspicious family history, or maybe they presented, they've had thrombocytopenia their whole life, and then now they're presenting with MDS or something. If you have a suspicious presentation, even if the gene test is negative, I would still recommend going ahead and doing germline.
Thank you. We have 2 questions left. This next question is referring to some mutations. The question would like to know, is SF3B1 a serious mutation, or is it found in low-grade MDS? And what about TET1 or TET2?
Excellent question. So good news. Those are the low-grade mutations. So TET1, TET2 is the more common one that I've seen. And SF3B1, these are found in CHIP a lot. So if you remember, the CHIP is where the patient, it's just like the random mutation, and there's not anything wrong with the patient, and they don't even have cytopenias. So TET2 mutations can be found frequently in CHIP. In MDS, actually, with the new classification system that's going to come out here in a month or two, SF3B1 defines a low-grade MDS, and actually it has long been considered a favorable mutation to be seen. So as long as you don't have other high-risk features of the MDS, like high number of blasts or whatever, as long as you don't have high-risk features, that SF3B1 is a good prognosis, and they tend to do very well.
Thank you. And our last question is in regards to PNH. What is the difference between intravascular versus extravascular hemolysis?
Great question. Okay, so intravascular hemolysis means that your red blood cells die inside your blood vessels, and that's usually what's going to cause increased LDH and the red urine and other symptoms. I think it can be harder on the patient. Like, it has other things that go along with it that they give the patient like feelings of being ill and stuff. Extravascular hemolysis means that the red blood cells are being gobbled up, usually in the spleen, and sometimes other tissues. So that, you'll still have anemia and the consequences of that, but it won't be the same as having that intravascular hemolysis, and you won't have the urine turning brown or the other things that can go along with that.
Well, thank you so much, Dr. Neff, for sharing your time and your expertise with all of us and answering all of the great questions from our participants today. If you'd like to watch this webinar again at a later time, it will be available on our website within just a few business days. If you have any additional questions, please feel free to send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, or submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 39 years. This concludes our program. Thank you again, Dr. Neff.
Thank you.